A warm welcome to everyone to the anesthesia classes. The topic that we are going to deal today is temperature monitoring. See, when we talk about temperature monitoring, the type of questions that have been structured are quite straightforward, and thus in this presentation we are going to deal only with certain key points of the temperature monitoring. When we come over to temperature, believe it or not, but it is one of the most important monitors intraoperatively, but yet it is the most neglected one. Talking first about the thermoregulation. What is thermoregulation? It is the ability of an organism to maintain the body temperature within certain boundaries. That is to maintain the homeostasis of the body. Please remember these values. The normal temperature of a body is 36.5 to 37.5 degrees Celsius. What is hypothermia? It is less than 36 degrees Celsius. And then comes two other words. One is hyperthermia and the other is hyperpyrexias. Hyperthermia means a temperature above 38 degrees Celsius, and hyperpyrexia is anything which is above 40 degrees Celsius. Normal 36.5 to 37.5, hypo is less than 36, hyperthermia is anything above 38, and anything which is more above 40 degrees Celsius is hyperpyrexias. Now, how is this thermoregulation done in a body? See, the thermoregulation is done at the level of hypothalamus. Please remember, hypothalamus is responsible for the thermoregulation of our body. We have afferent sensing fibers. For cold receptors, we have A delta fibers, and for warm receptors, we have unmyelinated C fibers. Very important to note, the cold receptors, the fibers carrying the cold sensation are A delta fibers, and the warm sensation is carried by your C fibers. They carry it via spinothalamic tract, eventually to your hypothalamus. And then the body behaves. That is, there are certain behavior responses, we can have emotional responses, and eventually the autonomic responses are seen. When we talk about the autonomic responses, these are like your vasoconstriction, vasodilation, shivering, non-shivering thermogenesis, or your sweating. Behavior is like if you're touching something hot, your body will move away from that hot object, or you dress appropriately to the weather. Whether it is cold, you choose your sweaters, it's hot, you choose your cotton clothes. That is your behavioral response to the change in the temperatures. So this is, again I'll repeat, the cold signals are carried by A delta, warm by unmyelinated C fibers via the spinothalamic tract. They go to hypothalamus, and then central regulation is there, and you have your efferent response in way of behavior regulation and autonomic regulation. And this is where your anesthesia is going to work. That is, under general anesthesia, obviously there is no behavior responses that can be seen in the body, and this autonomic regulation is also blunted by the anesthetic agents. The normal body temperature I've already told you, but there is something which is also worth remember is the circadian rhythm. That is, we have plus minus 2 degrees Celsius change when we see in the morning, in the afternoon, and in the evening. And obviously, at the time of the menstrual flow in the women, the circadian rhythm is there, leading to hot flushes. That is, we have plus 2 degrees Celsius temperature rise, which is physiological in nature. When we talk about the temperature of the body, you all have to remember that we are talking about the core temperature. Okay, there are three kinds of temperatures. One is core, one is near core temperature, and the third are peripheral temperatures. The core temperatures are the temperatures when we talk about the complications related to temperature, whether the patient has hypothermia or hyperthermia, we talk about the core temperatures. These are the temperatures from those organs of a body which are highly perfused and they're highly reliable. If asked which temperature is most reliable, it is the core temperature of your body which is highly reliable because there are least perturbations or least changes or least disturbances which are seen in the core temperature during your intraoperative or maybe during certain very major surgeries also it has been seen, like for example cardiopulmonary bypass. During cardiopulmonary bypass also it has been seen that core temperatures have very rapid perturbations, that is they change very rapidly, and thus they help us in knowing the hypo and hypothermias very well in comparison to your peripheral temperatures or your near core temperatures. So now from where do we actually get the core temperatures? I've already given you one hint. When we talk about core temperatures, we are talking about certain organs which are highly perfused. And the best representation of the core temperature is via your pulmonary artery blood temperature. I repeat, the best representation of the core temperature is via pulmonary artery blood temperature. Now, the questions can be framed in two senses. One, most reliable area where the core temperature can be taken. The most reliable is your pulmonary artery. But the second could be the most useful or the most commonly used is your distal esophagus, because pulmonary artery blood temperature monitoring is quite invasive. So the most useful or the most commonly done is your distal esophagus. Please remember that when we are talking about the normal body, in the normal body, the peripheral temperatures, that is your temperatures of your limbs, is always 2 to 4 degrees Celsius less than your core temperature. And there is a gradient, thermal gradient that is formed because of which the heat flows from the core temperature to your peripheries. So there's certain definitions which are quite frequently asked. The first is the threshold temperature. What is the threshold temperature? It is the temperature at which our body starts reacting to the temperature changes. For example, the temperature at which shivering starts or the temperature at which sweating starts. What does our anesthesia do? What our anesthetic agents do is that they decrease the shivering threshold and they increase our sweating thresholds. Okay, like for example, in a normal human being, suppose the shivering starts at 36 degrees Celsius, but under anesthesia, maybe the shivering will start somewhere around 32 and 33 degree Celsius. The same goes for sweating. Suppose we start sweating at 38, but under anesthesia, we will start sweating at around 39 or 40 degrees Celsius. This is how they are going to blunt our autonomic responses to the temperature change. What our anesthetic agents do? They decrease the shivering thresholds and they increase the sweating threshold. This is done by almost every anesthetic agent. Whether it is general anesthesia we are talking about or we are talking about your regional anesthesia. Coming over to one other definition, that is interthreshold range. See, interthreshold range is that range of temperature at which the autonomic responses are not activated in our body. In general, we have a very less range of only 0.2 to 0.3 degrees Celsius, like this. In a normal human being, if you see the range between the shivering response and the vasodilation, that is the sweating response, is very less. This is the interthreshold range at which the autonomic responses are actually not working. But under the anesthesia, what the anesthetic drug do? They increase this interthreshold range, which was only 0.3, they increase it to 2 to 4 degrees Celsius, and at this is the range in which no autonomic responses are going to be activated in your body. So one thing worth remembering here is what kind of animal the human being becomes when he is anesthetized. Our human body becomes poikilothermic. Under anesthesia, we behave like poikilothermic animals. Please remember this. Next, we have thermoneutral zones. Thermoneutral zones is that range of temperature where a healthy adult is able to maintain the body temperature without using any extra energy above a basal metabolic rate. That is your thermoneutral zone of the body, which is 25 to 30 degrees Celsius. At this range, we are able to maintain a normal body temperature without using some extra over our BMR. Okay. Now coming forward to certain standardizations which is required when you talk about your operation theaters. The thing that I've given in bold is something that you all have to remember. The first, what is the OT temperature that is required? The optimal OT temperature which has to be is 21 plus minus 3 degrees Celsius in adults. And when we talk about children, it is 25 plus minus 3. Generally given the range of 28 degrees Celsius, and here 25 to 26 degree Celsius. This is the normal range of OT temperatures that has to be maintained for sterilization as well as comfort. Talking about the humidity that has to be maintained in the OT is 40 to 60 degree Celsius. Okay, this is the OT temperature, humidity which has to be maintained, and there has to be a minimum of 25 air changes per hour, which means that the whole air which is present in the operation theater that has to have a turnover of 25 changes per hour. These are three values that are worth remembering to everyone. OT temperature has to be maintained at the range of 21 plus minus 3 degrees Celsius with the humidity of the OT to be 40 to 60 degrees Celsius. And the whole air of the OT has to be circulated and changed at a speed of 25 air changes per hour. Moving forward to the temperature again. See, thermoregulatory impairment is under general anesthesia as well as under central neuraxial block. Please remember, whenever the patient is under regional anesthesia, the first thing that happens is vasodilation. Below the block, suppose you have given the block at the level of T12. Below T12, there is a vasodilation response because of which you have increase in the evaporation or increase in loss of heat from the body, leading to hypothermia. Very susceptible, the patient becomes very susceptible to hypothermias. And moreover, the autonomic responses are also blunted by your central neuraxial block. The afferents are not working. Your fibers are no longer carrying your response of the receptors to your hypothalamus. There is nothing wrong with your hypothalamus, but your afferents are not working, thus increasing the threshold of sweating and decreasing that of shivering. See, when we talk about the how are we going to actually monitor, we are not going to go into detail about the instruments that are used for the monitoring of temperature in operation theatre. The only question which have been asked and only thing that you all have to know is that we have something known as thermistors and thermocouples which are used for monitoring in operation theatres. And these thermistors and thermocouples are made up of an alloy which is a copper nickel alloy, also known by the name of Constantin. Just remember one line. we use thermistors and thermocouples for monitoring equipments, which is made up of copper nickel alloy, which is also known by the name of constantan. That's it. Now, one thing that is asked quite frequently is why infants are very prone to hypothermia. See, when we talk about infants, they are very prone to hypothermia because of the increase in their surface area. Infants have a very large surface area in comparison to adults, and thus the heat loss is very high, and thus they are very prone to hypothermia in comparison to human beings. I'm sorry, in comparison to the adults. One of the questions that was asked in the previous year was how is the heat lost from the human body? Which are the various mechanisms of heat loss and what is the sequence in which the heat is lost? So remember, the most heat that is lost from the human body is via radiation, followed by convection, evaporation, and eventually conduction. This is the least important mechanism for heat lost. You have to remember the sequence: radiation, convection, evaporation, and eventually conduction. This is how the heat is lost in decreasing order. Radiation, convection, evaporation, least important is conduction. These are the various mechanisms which can lead to hypothermia in the body. Intraoperatively, one of the most important value which you all have to remember is this. That is 1 unit of RBCs, 1 cold unit of RBCs that you all transfuse as interns also can lead to decrease in the can lead to decrease in the body temperature by 0.25 to 0.35 degree Celsius. And in general also our anesthetic agents lead to decrease in the basal metabolic rate by 20 to 30 degree Celsius. I've already explained to you this, that anesthetized patients behave like poikilothermics and thus their body temperature is now determined by the environment. Our autonomic autoregulation is blunted and we are behaving as the body temperature is behaving, like the environmental temperature or the OT temperature is changing. When we talk about the heat losses from a body intraoperatively, these losses are generally in 3 phases. The very first phase is the redistribution phase, where there is a decrease by only 1 degree Celsius. Second is a gradual decline phase, in which the heat loss is more than what is metabolically being produced in our body. Okay, and 90% of the heat loss is via radiation and convection, and very less through evaporation and conduction occurs. And eventually in phase 3 we have a steady state, that is a plateau state is there, in which the heat loss is equal to the heat production. You have to remember these 3 stages of heat loss in our body. The phase 1 is the redistribution phase, in which the temperature decreases by 0.5 to 1 degree Celsius. The second is the gradual decline phase, in which the heat loss is more than what is being produced, maximum by radiation and convection. And in phase 3, we have eventually a steady state, that is a thermal plateau is there, and the heat loss is equal to the heat production. Okay. Now moving forward to certain standardization which had been given for the monitoring part. See, every human being who was posted for operation theatre, if the question asked is when should temperature monitoring be started, the answer to this question is it has to be started before induction. The first temperature that has to be taken is 1 hour before you start inducing the patient, because anesthesia always has to be given when the body temperature is 36.5 degrees Celsius. We don't give anesthesia if the patient is already hypothermic. So 1 hour before induction, you start your temperature monitoring, and anesthesia always has to be given if the temperature of the body is 36.5 degrees Celsius. Then intraoperatively, every 30 minutes you have to check the temperature, and in post anesthesia care unit every 15 minutes initially, and then the range of the time interval can increase as per the requirements, whether the patient had suffered from hypothermia or the patient had an episode of hyper or hyperpyrexia intraoperatively. This is a star question. See, I've already told you when we talk about the temperature monitoring, we are only going to talk about the key points and the facts, because the details of temperature monitoring have still not been asked, and yes, potentially also there is a very less chance that this all will be asked in much more details. So the best thermoregulatory mechanism that is preserved during anesthesia. See, I told you about various autonomic responses to the change in the temperature, out of which the best thing that is preserved is your sweating. Please remember, sweating is the best preserved autonomic response of our body under anesthesia, because there's a great confusion between shivering and sweating. The answer to this is sweating. Which thermoregulatory mechanism is best preserved during anesthesia? It is sweating. Talking about a recapitulation of the monitoring sites, I've already told you the best site for the core body temperature is your pulmonary artery, but the most used is your distal esophagus. Okay, when we talk about the esophagus, you have the esophageal probe that is inserted into the body. And till what point are you going to insert that probe? Till the point you are going to listen to your heart sounds. And then nasopharynx and tympanic membrane are two other sites which can be used for the core body temperature. The question that asked are, which of the following sites can be used for core body temperature, maybe except, or which of them can be used, which are pulmonary artery, distal esophagus, your nasopharynx, and your tympanic membrane. The near core body temperature is from the sites that you regularly use, your oral and your axillary site. And some things which are quite unreliable, your rectal temperature, the bladder temperature, your temporal artery, or the forehead temperature. They are highly unreliable sites for monitoring of temperature. Other than the temperature monitoring, which is that the patient goes hypothermia or hyperthermia, is there any other things that this temperature change can bring to the body, especially under anesthesia? If you remember, there is one more monitoring known as the neuromuscular monitoring. Temperature changes actually affect the neuromuscular monitoring because our nerves and muscles respond very poorly to the stimulation if they are hypothermic. So, cool nerves and muscles respond poorly to your neuromuscular monitoring. Then, is there any other use for your skin temperature? Yes, there is one use for the skin temperature. I've already told you before that whenever a central neuraxial block or a peripheral nerve block is given, there is vasodilation, and thus the temperature of that area increases, which can be used as a surrogate marker for the success of your blocks. Third, and one of the most important uses of temperature monitoring is in the detection of a very serious anesthetic complication, which is malignant hyperthermia. So these are three more uses of temperature monitoring. One, during neuromuscular monitoring, the temperature has to be monitored to see the response of the ulnar nerve. Second, to check as a surrogate marker for the success of your blocks. And lastly, and one of the most important, in the detection of malignant hypothermia, which is one of the most serious and dreadful complication of anesthesia. See, when we talk about hypothermia, that is the most common complication of temperature regulation. But yes, hyperthermia can also happen intraoperatively, which could be iatrogenic. You have warmed the patient a lot. It could be infectious. It could be a fever. It could be because of your mismatched blood transfusion. Of course, malignant hyperthermias. And lastly, if there is blood in the fourth cerebral ventricle. Once this was asked as what are the causes of perioperative hypothermia, that is why I am emphasizing upon it. It could be because of warming iatrogenically, infections, fever, or blood in your fourth cerebral ventricle. Mismatched blood transfusions can lead to hypothermia, and also one of the most important reasons, malignant hyperthermias and thyrotoxicosis, which increases the basal metabolic rate of your body and eventually landing the patient in hyperthermias. Talking about perioperative hypothermias, see, hypothermias can have grave consequences intraoperatively. It can lead to increase in the chances of infections, your coagulopathies, delayed anesthesia recovery because under hypothermia your metabolic rate decreases and thus your enzymes also start decreasing. The work of the enzymes is decreased, and thus your anesthetic drugs remain in the body for quite a long period, which increases the recovery phase of anesthesia. More or less, the most important is the oxygen consumption. Whenever the patient is under hypothermia, we have myocardial decompensation, which can eventually lead to myocardial infarction because of the increased oxygen consumption by the body if the body is responding to hypothermia in the form of shivering, etc., and eventually landing the patient in metabolic acidosis because of the increased oxygen consumption by the body. But is the hypothermia can be useful? The answer is yes. Now, which are the places where hypothermia can be useful? The two most important areas where hypothermia is useful is return of spontaneous circulation, that is after cardiac arrest. If the patient revives, then the patient is kept hypothermic in order to decrease the metabolic rate and help the body to revive back. So uses of hypothermia is return of spontaneous circulation, plus, the hypothermia helps to decrease the cerebral metabolic rate by 7% for every 1 degree Celsius decrease. So, there are certain conditions in which we need the brain to relax. In those cases, also, we prefer the patient to be on the lower side of the body temperature, and thus helps in decreasing your intracranial pressure by decreasing the cerebral metabolic rate of oxygen consumption. Lastly, hypothermia helps us by decreasing the free radical formation. The free radical formation, which are some inflammatory markers which can lead to marked inflammation in the body. Hypothermia also helps in controlling those free radical formation. So these are three areas in which hypothermia can be useful also. Done? Lastly, coming over, how can you prevent hypothermia intraoperatively? See, I have told you about the consequences, the bad and the good consequences of hypothermia. One thing, a key question which I want to tell you all is, how do you detect whether the patient has hypothermia? One is, of course, you can feel. But one of the most important things that you can notice in, suppose you're as an intern, you're going to operation theater, is micro bleeds from the surgical sites. This is one of the most important things to notice. If the patient is hypothermic, he is going to have micro bleeds from the surgical site. This is something which is asked quite often. Also, one of the consequences of hypothermia is coagulopathies, leading to microbleeding from the surgical area, which becomes quite difficult to control. So when we talk about the prevention part, it is before induction, we can give certain forced air warmers. The airway heating has to be done, humidification has to be done, fluid warmers are there. We have then certain things known as the bear huggers. We have special mattresses which are present to prevent the heat loss from the bodies, which are known as the huggers mattresses. They hug your body, and then we can warm your fluids, you can warm your blood. The temperature can be maintained. Then we can have certain passive techniques of preventing hypothermias, which can be your blankets, your drapes, your plastic sheets, the sleeping bags. And eventually you have active warming devices, that are your forced air warmers, your negative pressure water warming systems, your radiant heaters. So these are all the equipments which can be used to warm the body either passively or actively. Lastly, and one of the most importantly asked is malignant hyperthermia. I like to just give you a brief outlook about this topic. See, malignant hyperthermia, when we talk about, there are certain key questions which are asked. The first, it is a autosomal dominant reaction. And that is one of the reasons always when we take the pre-anesthetic checkup of the patient, we always ask about the anesthesia history of the patient or the family members, because malignant hyperthermia is autosomal dominant. It is a biochemical chain reaction that occurs because of certain triggering agents. The triggering agents for malignant hypothermia are two that you all have to remember. One is scolin, your depolarizing agent, and other are your inhalational agents. Your halogenated inhalational agents are responsible for malignant hyperthermias. Okay, what happens in malignant hyperthermias? Actually, there is alteration in your ryanodine receptors. Your ryanodine receptors are altered, or your dihydropyridine receptors, which are calcium channels. They get genetically mutated, because of which your sarcoplasmic reticulum is not able to sequester the calcium, and thus you have excess of calcium in the body. And because of that excess of calcium, I hope you all remember that calcium ion is required for the muscle contraction, and thus you have a sustained muscle contraction and lot of breakdown in the body, leading to a hypermetabolic state. This is what is going to happen in malignant, that is malignant hyperthermia, a excess of calcium leading to sustained muscle contraction in the body. The drugs are your inhaled general anesthetics and your scolin. What are the signs and symptoms? Out of this, one thing you all have to remember is the first change which is seen is, it is not hyperpyrexia. Please remember this. It's not fever. It is increase in EtCO2. A very high increase in your EtCO2. This is your time and EtCO2 curve, and this increases like around 80 or 90 mmHg. There is a gross increase in the amplitude of EtCO2. This is one of the first coming signs of hyperthermia, and it is not temperature, as it is a late manifestation of hyperthermia. How do you treat it? See, if there is an unexplained increase in EtCO2, you have increase in metabolic rate, your tachycardia, temperature, oxygen consumption, CO2 consumption, everything increases. The first thing is to stop all the triggering agents. You stop your inhalational, you stop the surgery, you ask for help, you convert the patient into TIVA, that is total intravenous agents are given to the patient. Immediate management will mean 3. Stop all the triggering agent, resuscitate the patient, stop the surgery. Call for active cooling of the body. Lastly, we have one drug that is used for malignant hypothermia, that is dentrolin, which is given in the dose of 2.5 mg per kg. Okay. And of course, you have to monitor then for all the consequences of hypothermia, which could be hyperkalemia can happen, arrhythmias can be there, metabolic acidosis can be there, or myoglobinuria can be there, and everything has to be treated side by side symptomatically. The drug of choice for malignant hypothermia is dentrolin. Continuous monitoring and follow-up of the patient has to be done. And one blood investigation that is very important in malignant hypothermia is your CPK levels. Creatinine phosphokinase levels are very important. So, giving a brief again of malignant hypothermia, it is autosomal dominant. Rhinodine or dihydropyridine receptors are faulty, leading to increase in calcium, thus increase in your metabolic rate, and the first sign that comes is increase in your EtCO2 level, an unexplained abrupt high jump of your EtCO2, and eventually stop everything, resuscitate the patient, stop the surgery, and cool the patient and give dentrolin to the patient. So when we talk about temperature monitorings, you have to remember the effect of anesthesia, decrease in shivering, increase in sweating threshold. The monitoring signs, most important pulmonary artery, most useful distal esophagus. You can go for periphery also, but they are unreliable. The consequences of hypothermias. How can you prevent hypothermia? What are the standardization? What is the OT temperature that has to be maintained? The humidity which has to be maintained? And why infants are more prone to hypothermia in comparison to adults? And lastly, your malignant hypothermias. That's all for temperature monitoring. Have a good day. Thank you.